Hello, my name is Karl Lorenz. I serve as the Section Chief for Palliative Care at Stanford University and the VA Palo Alto, where I'm also a health services researcher and a primary care physician as well as a palliative care doctor. It's my pleasure today to moderate our panel talking about federal and national issues in improving serious illness care. I'm going to let the panelists introduce themselves, starting with Dr. Annette Schneider.
I'm Annette Schneider. I'm here from the Center for Medicare and Medicaid Services, and specifically, I work in the Center for Medicare and Medicaid Innovation. It's our pleasure to be able to be here today and to share our thoughts with you about the work that's going on in this area, and perhaps to reassure you that this is more than just a blip on our radar. We are working actively with many of you to proceed to address this. So CMS takes it very seriously that we have a fiduciary responsibility to the public in using tax dollars to provide meaningful, effective health care. And through its historical efforts with various demonstrations and currently through models underway at CMMI, we are seeking to improve beneficiary health and healthcare delivery through deliberate adjustments to programs and payment and spending. So some of you are playing pivotal roles in this area in terms of being conceptual champions of the work, building coalitions, and being vanguards of care delivery. Sometimes in partnership with CMS, but we think always in an effort to improve the health care of the American public. So to be effective, CMS considers the advances that are being made in the field. We frequently consult with subject matter experts, some in this room, some to my right, and left, I'm sure, to understand how we can finance exploration of new approaches. We try to make sure we engage all perspectives and stakeholders in that work. And sometimes we take risk. We take measured risk. Sometimes we ask you to take risk along with us. I'm sure many of you are familiar with the alternative payment models and our QPP approach in terms of payment. So it's a big ship that doesn't turn easily. I'm working right now with the Medicare Care Choices model that some of you may be familiar with. And as we're going through that experience, sometimes we need to make adjustments, and it's not easy, even inside, to change even a small thing that we didn't quite get right. So we try to make sure that as we enter into these new endeavors that we have looked at things very carefully. We have to make sure that there is data that supports the change that we recommend. We do this first on a small scale and perhaps in a slightly different way than some of you might be able to. It takes more than having a good idea or even having sort of the actuarial proof that this will save money and improve quality. But we have to know, we have to use comparison groups. We have to know what the data sources are. We all know that administrative data isn't quite enough to get that job done. We have constraints such as data collection. We can't ask providers to give us data that we know we need to make sure what we're doing is the right thing. So we have to, again, consider it all very carefully. So we are closely observing the work in the field. We've been working with the American Academy of Hospice and Palliative Medicine and a coalition to transform advanced care. We're familiar with their proposals and have been discussing those with them. But there's a saying that it takes more than an act of Congress, or it takes an act of Congress to make change. And I'm here to tell you it takes more than an act of Congress. The Medicare, Medicaid Modernization Act, the Affordable Care Act, the Impact Act are all actively underway and part of our thinking. So I hope that today I'll be in a listening mode to hear more about what your thoughts are, and I hope that I can perhaps respond to some of your questions and thoughts. So thank you for allowing us to be here.
I'm Joe Rotella, Chief Medical Officer of the American Academy of Hospice and Palliative Medicine, AAHPM, and I served on a task force headed up by Dr. Phil Rogers that developed a proposal for an alternative payment model for people with serious illness. First, some background. Palliative care as defined by Medicare, is patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care throughout the continuum of illness involves addressing physical, intellectual, emotional, social, and spiritual needs. So many studies have shown that palliative care improves symptom control and the experience of care and lowers costs. It sometimes even improves survival. Traditional fee-for-service payments cover some medical visits and care planning activities, but they're insufficient to support the interdisciplinary team, including nurses, social workers, and chaplains, to address suffering in body, mind, heart, and spirit. And while the hospice benefit provides a comprehensive form of palliative care, it's limited to those thought to be in their last 6 months of life who are willing to forego intensive treatments for their underlying illness. Now, only about half of Medicare beneficiaries who die receive hospice care, and most have it for just days or a few weeks. We need ways to deliver palliative care whenever it's needed, not just at the end of life. The population with serious illness is marked by high risk of mortality, negative impact on quality of life and daily function, and burdensome symptoms, treatments, or caregiver distress. That's simple enough, but it can be hard to identify all those traits with limited data such as claims. Now some good news. In March of this year, AAHPM and the Coalition to Transform Advanced Care, or CTAC, presented proposals developed separately to the Physician-Focused Payment Model Technical Advisory Committee, or PTAC, which was created to solicit, review, and recommend APMs to the HHS Secretary for testing or implementation. Both proposals deliver home-based palliative care with an interdisciplinary team and 24/7 coverage, a per beneficiary per month payment. Different types of entities can participate, such as physician practices or facilities, and incentives for provision of high-quality care. PTAC recommended both APMs for testing with the highest possible priority. They also suggested that the Center for Medicare and Medicaid Innovation, AAHPM and CTAC, work together on refining the proposals, and those channels are already open. PTAC highlighted concerns about the unintended consequences of financial incentives for providers based on cost saving, challenges measuring quality, making risk adjustments, and setting performance benchmarks, and problems with basing eligibility on life expectancy. The devil's in the details, but I believe we're well on our way to finding solutions to improve access to palliative care for those who need it most.
My name is Peggy McGuire, and I am the executive in charge of palliative care at Cambia Health Solutions. I also serve as the president and board chair of the Cambia Health Foundation. Cambia is a family of companies that is dedicated to changing the way people experience health care. Our overall mission is to make healthcare more person-focused and economically sustainable. We're your neighbor to the north. Our headquarters are in Portland, Oregon, and we are a family of more than 20 companies that are all focused on transforming the healthcare experience. We have about 5,000 employees in 30 states, and we serve over 70 million Americans with simple and personalized healthcare experiences. About a decade ago, we began investing heavily in palliative care because we believe that it changes the experience of people with serious illness. Our philosophy really is that serious illness is a human issue that impacts the whole family and not primarily a medical issue. So we're looking for innovative solutions that serve both the patients and their caregivers. This is our comprehensive approach to palliative care across our enterprise. We really started with corporate philanthropy in the Cambia Health Foundation, and we've invested heavily into palliative care, as I said, for about a decade. We've invested in hospital-based programs in the Pacific Northwest, really building the capacity in the field and standing up programs. We invested in LNEC, the nursing education programs. We set up the Cambia Palliative Care Center of Excellence at the University of Washington to invest in innovation, clinical excellence, and research. We set up an endowed chair position in pediatric palliative care at OHSU and Dornbecker. And we've also engaged in public engagement and awareness campaigns, as you heard from the Dying in America report. That was dearly needed. Our current focus is our Sojourn Scholar program, and we are investing in emerging leaders in the field of palliative care, investing in their development as leaders and also innovative practices that they bring to the field. And what I see one of our scholars is in the room today, and I just like to call her out. She works at Stanford and is just a wonderful colleague working on some really interesting projects. And you also mentioned another scholar who's been working on the advanced care payment models. So through our insurance, I know I'm getting short on time, but we also have invested in palliative care through our regional health insurance plans. We're known as the Blue Cross Blue Shield plans in the Pacific Northwest, and we have developed a personalized care support program that includes expansive benefits for palliative care, caregiver support, and specialized care management. We've also, I'll skip over the platform and talk about our strategic investments through Echo Health Ventures. We're investing in solutions that address aging, caregiving, and caregiver support. This is really our palliative care program in the health plan, and it's really what's been called the most comprehensive set of palliative care benefits in the industry, and we're trying to support the entire spectrum of needs for palliative care as soon as someone is diagnosed with a serious illness, from birth to natural completion of life. We also offer remission support to someone who's been part of our palliative care case management program but then has recovered. I tried to show our alignment to what CAPC has put together, a document that's called Serious Illness Strategies. If you haven't seen this, it's a really good primer, Serious Illness Strategies for Health Plans and Accountable Care Organizations. And I tried to align our work with the CAPC recommendations, and I won't go into it, but I noted in yellow where I think we still need some work. And I'm out of time, but I look forward to the discussion, and I thank you all for being here and being part of this panel.
We were started about 5 years ago by Senator Bill Frist, who is a Senate Majority Leader out of Tennessee, and Brad Smith, who's our CEO. And through a mix of both personal and professional experiences, we landed on a similar set of convictions as what you've heard from the other panelists today, which is that serious illness care is truly broken, and end-of-life care under the fee-for-service environment is not working effectively for patients, for providers, or for risk-bearing entities. And so through that conviction, Aspire Health was born by partnering with any risk-bearing entity. We started with Cigna HealthSpring in Tennessee, functioning as a physician practice. And so we have a team of board-certified palliative care physicians, nurse practitioners, RNs, social workers, chaplains, and community health workers. And we service patients primarily in the home, visiting those patients who have on average 2.8 chronic conditions, 15 to 20 medications, and advanced and serious illness. And what we found is that by heavily investing in those patients, we can in fact improve the quality of care that they receive. We can improve their patient experience, and we can ultimately reduce costs as well. And through that experience, we've had the privilege of scaling to about 25 states and 70 markets, working with most of the major national and regional plans, as well as ACOs and risk groups across the country. Our team's now about 750 people, and we've serviced about 50,000 patients across the country. And so that's quick background on us. Very excited for the conversation today and happy to address any questions folks may have.
Puneet, thank you for that introduction. It's a great segue. I thought first we'd talk about a few things that are in the news. And one thing, of course, that's in the news that this is a wonderful panel to discuss is the acquisition of Aspire by Anthem. And along with CareMore, obviously something is happening. And I thought it would be really helpful just to, if you could offer your insights on that recent news, whatever you're able to share. And then allow us as a panel to maybe respond to that and think a little bit about what it signals for what may lie ahead.
We've worked with Anthem for a number of years as a partner for our company. And so we've had the privilege of servicing their Medicare Advantage and now Medicaid and commercial members across the country. And as I mentioned earlier, through that experience, along with the experience of our other plan partners, we've really seen a steady state of results. I think when you combine that with, across the country, a growing trend around folks recognizing that our most vulnerable patients are in fact oftentimes receiving the worst quality of care, there's now a mindset shift, I think, working across the country where folks are actively looking to invest in this space. And I think you see that with some of the comments here earlier in terms of CMS. I think you see that in terms of health plans like Cambia and certainly health plans like Anthem as well. And so I think the vision that folks are seeing is that by investing in risk models where you can improve quality of care and reduce costs, there is a tremendous opportunity. And so from our vantage point, nothing really changes in terms of our mission and opportunity set as we go forward with Anthem other than a continued set of resources and investments to really allow our company, as well as the other models you're hearing about today, to scale across the country.
When I first saw the news about the acquisition, I thought, this is good news for Americans because, Anthem covers so many people across the country. And I think of it not so much from the cost equation. I know that's really important, but I thought of it from the patient experience perspective because so many people, with multiple chronic conditions have difficulty getting out to their appointments. And I think, the future site of care is in the home for many people. We really should think about delivering care where the patient wants it and where their experience will be greatly enhanced. And we have the technology and we have the ability to do that. So I think it's great news for Americans.
So I agree that it's good news. It's nice to know that there's value, proven value in providing home-based palliative care, and that it might have a sustainable business model behind it. In our proposing at the Academy an alternative payment model, one thing we were sensitive to, though, is that there probably isn't just one care model that works for everyone in all settings, particularly in rural settings or where there's healthcare workforce shortages. We might need to have flexibility in how certain services are provided. And I did want to bring up one of the concerns in the PTAC report that recommended both CTAC's and the Academy's model for testing was a concern, and there was a lot of discussion at the hearing about this, around we all appreciate that good palliative care saves money, but it doesn't exist to save money. That is what we call like a happy side effect. It's like a side benefit that's very fortuitous. But palliative care would be the right thing to do even if it didn't save money. And so one of the things I'm always concerned about is if we link it too much to the money we're saving, are people going to start distrusting it? Does it become a barrier to doing what's really right? So I was wondering if you had any thoughts about that.
Yeah, happy to share some thoughts on that as well. And I think, Peggy's comments were spot on, which is there is a massive shift in terms of care being delivered in the home. And to Joe's comments, the reason for that is, I think what June mentioned earlier, 70% of patients across the country want to be in the home, not the hospital. They want to be with their family and loved ones, not the physician. And so it's really interesting when you look at our patient population. When you look 12 months out from expiration, average PMPM costs of between $1,500 to $2,000 a month, increasing to about $12,000 to $15,000 PMPM costs by the end of life. So no surprise, a quarter of the healthcare spend spent in that last year of life. When I first entered this space, the first thing that surprised me is in the data we see about 60 to 65% of those costs are hospitalizations. So it's patients ending up in the hospital 2, 3, 4, 5 times in that last year of life. Even when you look at specific disease states like oncology and cancer, where you typically think that there's going to be a huge prevalence of chemotherapy spend, that's certainly the case, but the majority of the spend ends up being unnecessary hospitalizations. And so the fact that most patients actually don't want to be in the hospital, yet that's where they're ending up, what we find when we visit our patients in the home is there's a prevalence of medical issues, but also social issues, resource needs, behavioral needs for these patients. And if you're not delivering an interdisciplinary team model, you're not actually bridging this gap that's created by fee-for-service. And so I think Dr. Rotella's comments are spot on, which is for our company and for our mission, it's really not about the ROI or the business case or savings. If you ask the majority of our company, folks who are delivering care in the home, when our nurse practitioner goes in the home, they're not thinking, oh, there's an ROI here. They're thinking, wow, I entered this space because I really want to service patients who have significant needs. And if I can help them better understand their goals of care and link a care plan to those goals of care, that's good for the patient and that's good for the family. And to Joe's comments, that's really the side effect to that. It's also better for the healthcare system. So that's really how we think about our model.
Your comments made me think about the importance of developing consistent standards and quality measures for home-based palliative care, and then defining value from the patient and the family perspective, and thinking about quality from that perspective.
When the news came out last week, it did go around our team very quickly. We are trying to be mindful of the business solutions that are occurring in this area. CMS generally is careful not to ascribe to a particular approach, but rather to facilitate the best thinking and clinically and financially in the market, I guess I might say. Our primary goal, as has been said here, is to ensure that beneficiary preferences and well-being and care is maximized, and then again that we are fiduciary responsible for the dollars that we spend. So we will watch and see how those things go.
And I'm going to take my moderator prerogative. One of the things I want to observe is that when we developed measures for inpatient care and ambulatory practice, that it was an 8-year journey to get from the evidence to NQF approval. And so it's a long time frame. It may be a while, even though some of that measure work has been done, and of course it's fast-tracked, it's still going to be a while before there are measures. So I want to turn the question a little bit, and I'm curious, what are best business practices? Given that we don't have quality measures, what are effective business practices that provide families and providers with the assurance that care is patient and family-centered?
I think this is a really simple thing to say, but it's listening to the customers and listening to patients and families about what they need and what they're looking for, and then designing the benefits and the services around their expressed needs. We recently hired a medical anthropologist and a person from the design center at Stanford, the human-centered design organization, to go out and do a listening tour and really identify what patients and families are saying are their needs. And we're calling those our anchors, and they are being used to look at any products and services and partnerships that we set up. But it really is, I think, starting with the end in mind and thinking about not divorcing our personal lives from our business, but thinking that, all of us are patients, all of us are caregivers, all of us have family members that we love and that will be part of this system, and thinking about from their perspective, what do you want the system to look like?
As we are looking at how we will address this area, be it through an actual model or through some of our current efforts, we have a number of models that are already looking at some patient populations, some particular venues of care for people with serious, advanced serious illness. We are carefully considering and trying to understand how we can know what the family and patient experience is. We have our various CAP surveys. They're not always tailored to the particular question that we're asking in a model, And again, as we devise new means of collecting that data for the purposes of developing a model or a demonstration, we have to sort of tread lightly on the burden to families and providers in collecting additional data. So the measures are of real interest and importance to us. Later this summer, we will present what our thinking is in this area so that we can get some feedback about this. We, of course, have NQF to rest on. We are able to, in the model development area for the Innovation Center anyway, to work around that a bit. We don't have to have measures that are NQF approved, but we do need to make sure that they are evidence-based, meaningful, and that we have the data to actually stand behind understanding what has happened. So it's not by any means necessary. We need to know how we got there and that where we are in the end happened because of the action that we took. So in terms of measure development and patient and family experience, it's a major consideration for us.
So it's funny, you said since we may have to wait to develop quality measures, what are good business practices? And we're coming right back to quality measures. And what I think is important is the concept I think we're all talking about here is shared decision-making with informed, empowered, engaged patients. And that means that there's a good quality of communication, that they've been heard and understood, that they didn't feel pressured, that they had the information they needed. And some of the CAHPS surveys that are out now have some questions that get at that kind of quality of communication. What we'd love to see is that validated in a home-based, seriously ill population. Because I do think that among the various kinds of quality measures we want to gather, we want to look at some outcomes, some patient-reported or family-reported outcomes. It turns out the quality of communication, I don't think is a satisfaction issue. That's an important outcome of care for this vulnerable population. So if I were developing a business practice in advance, I would set up a culture in my business that was patient-centered. Maybe we would have our own internal surveys about shared decision-making, about the quality of communication, about did you hear, heard, and understood, and not have a checkbox kind of care plan, but a care plan that I can audit and actually see that it's individualized for each patient's goals.
We do have a survey like that where it's not a one-time survey, but it's at different points in their engagement with us. We ask whether you felt listened to and whether you feel like you have enough information to build confidence in your own care delivery plan.
I would just echo the previous comments. I think what we're all hearing is the best business practices are actually just good clinical quality of care. And so everything we do from a business practice perspective is centered around that. That starts with the recruitment of our clinicians. And when we do that, it's focused around IQ capabilities, clinical capabilities, but equally importantly, EQ capabilities. Can you have advanced care planning conversations with patients? Do you have a good level of empathy? And there's a number of ways in which we can both qualitatively and quantitatively measure that. And then when our clinicians are doing their body of work, it's truly a balanced scorecard. And so it's everything that you've heard earlier today. It's, of course, patient and provider satisfaction. It's discussions around advanced care planning, completion of advanced directives, a range of clinical quality metrics. And importantly, it's also a question of what do you not measure. So we don't really measure any of the things that traditionally you measure in a fee-for-service environment. We're not measuring RVUs, or did you see the patient for 15 minutes, or what's your productivity. We're actively giving space for clinicians to really invest in their patients who have needs, and we're giving them data and technology and support and coaching to focus on those patients who really need their level of care most. And what we found is if you give clinicians the team and the scorecard and the resources, they will do the right things all the time. And so that's really the most important thing that we found is focusing the business practices on actually just empowering our clinicians to do the right thing for patients.
One other idea about best business practices is the concept of transparency. And so that's another value. It exists, I think, somewhat independently of patient-centeredness, but not entirely. And it seems in many situations where information and power are asymmetric that transparency is important. How do you build, while we're waiting for the group to ask us questions, how do you build transparency into business practices?
One of the things that we funded through our foundation was a project with the Robert Wood Johnson Foundation called Open Notes, and it basically says that the consumer, the patient, is the owner of their own medical records and they should be written in a way that's meaningful to the patients and their families. And so I think it requires a bit of culture change, and that's where philanthropy combined with business can help to promote culture change. But I think transparency in general has been something slow to come to healthcare. Even 10 years ago, maybe more than that, we started investing in making cost and quality information transparent to our customers about the physicians in our network, and that was seen as heresy at the time. And now I think that the concept of transparency is more accepted, but is it actually being practiced and in use? I think when we can put this patient at the center of their own care, that's when that's how transparency fits in. So
this incomplete information is a real issue, and I don't know if any of you that have ever worked in healthcare, how often neighbors or family members call you and they say, will you tell me which hospice I should go with, or which doctor I should go to for my consultation? And it's because, of course, they have no basis to tell who's good and who's bad. And so they come to you, an insider, and they think maybe you've got some inside information. Sometimes you do, and sometimes you don't. This is what's partly behind the idea of posting quality information and having things like Hospice Compare that can allow consumers then to make at least a semi-informed decision about which program they might want to use. And it's a fantastic concept, but it's only as good as the quality of the data that's put into it and as the context that's given to the consumer so they can understand what to make of the information. For example, if I chose Hospice A over Hospice B because their percent of spiritual conversations completed upon assessment was 92% instead of 91%, that's probably not the right reason to choose Hospice A over Hospice B. So there's a double-edged sword to transparency. We have to give people information that actually works. But I also think it would be great to let people know what things cost. I've always worked in nonprofits. Nonprofits have 990 forms I can pull up and look at, and I know who their board of directors is. I know what their CEO is paid. I know how much profit they put to the bottom line. I like that. I'm not able to do that with privately held companies. So as a consumer, I feel like I'm missing something sometimes.
Well, I think transparency for CMS is at something of a different level. It's mostly being transparent with the public about what we're planning to do, why we're doing it, and how we're doing it, and giving everyone an opportunity to provide feedback. I mentioned earlier that later this summer there will be a white paper published on the CMMI website to let you know what it is we're going to be doing in this area. We are staunch proponents of patient consent in terms of participating in our models. We don't just sort of insert them in ways that beneficiaries have to participate. So we do try to keep our activities as viewable by the public and the provider public also.
I'd like to thank the panelists and let everyone in the room know I think we're entering a break. So please enjoy your conversation, and we'll see you back in a bit.